Hello, everyone, and welcome to our Respiratory Critical Care webinar, which is very special today. We are talking about innovation in critical care pulmonology field, and we are going to focus on respiratory failure from assessment, evaluation to management. Hello, everyone, and welcome to our Respiratory Critical Care Fellowship, which is very unique flagship program accredited by the American Association of Continuing Medical Education. It's 1 year online fellowship program that is going to transform your clinical practice and your knowledge in the respiratory critical care field. So it's not based on monologue or one-way directional educational activities, but rather on engagement of our fellows and bi-directional educational process with a dialogue rather than monologue. So you will have a lot of journal clubs, MCQs, clinical case scenarios, case-based discussion. The e-learning process you will have in this respiratory critical care fellowship will be extraordinary, and also you will have access for the artificial intelligence simulation in respiratory critical care field, because we know that our retention rate is very limited when it comes to just reading or listening to for a lecture. We try to involve our fellows in at least audiovisual demonstration, discussion process, and we are aiming to get their clinical practice improved by adopting this new knowledge to their clinical practice and standard of care to improve our patients' outcome. This fellowship is structured as 3 modules, 16 weeks each. And again, it's mainly not only based on webinars or recorded lecture, but on engagement of our fellows throughout the materials. And everything is clinical based, and all of the scientific activities will be recorded, uploaded to a smart platform, and released to our fellows in a weekly basis. So our fellows will have the freedom to navigate throughout these materials during the whole year, but they need to submit their tasks to answer their MCQs, clinical case scenarios, on a weekly basis. So all of our fellows' activity are monitored, and the assignments will be in the smart platform, and there will be a quantitative and qualitative evaluation, not only based on their scores, but based on their performance, overall engagement, and the learning curve throughout the whole year. So here is the module 1, which is focusing on foundation and the basics of respiratory critical care. So we start with the anatomy, simple physiology, to how to read and interpret blood gases. Then we'll move to several weeks of imaging and respiratory critical care, from chest X-ray to CT, MRI, thoracic ultrasound with the point of care ultrasound. Then we'll move to different infection from viral, bacterial, and fungal pneumonia and pneumonitis. In module 2, are going to focus mainly on oxygen therapy and mechanical ventilation, different kind of mechanical ventilation, from non-invasive to invasive, from non-conventional to conventional mechanical ventilation. In module 3, this will be an advanced respiratory critical care module. So we'll be teaching you how to best manage your patient with the analgesia, with sedation, neuromuscular blockade. Also, we are going to talk about different aspects of the simulation, artificial intelligence, advanced technology, including electric activity of the diaphragm, advanced monitoring with esophageal balloon, advanced monitoring with electrical impedance, respiratory muscle assessment, and ECMO therapy. So we will help you to recognize your limitation, to understand your strength, and we are targeting to let you to lead this field and to master the field of respiratory critical care. And upon completion of this 1-year fellowship, you should be an expert in the respiratory critical care field, and you should graduate from a trainee and the mentee level to a trainer and a mentor level, and you should receive a graduation certificate from the American Association of Continuing Medical Education. If you haven't joined us yet, please do as soon as possible. There is a 15% promo code with a discount, 15% that is going to expire shortly. Please use early 15, the promo code, to get this 15% discount and join our enormous diversity and very high good quality and quantity of fellows that are joining our program. Again, the promo code is early 15 and it's going to expire soon. Our aim from all of these educational activities is not just to give you knowledge, because knowledge has no value until we improve our patients' outcome and we adopt this knowledge in our clinical practice to improve the standard of care of our practice. And the great aim of education is not the knowledge itself, but the action. And I really thank you so much for listening, and we'll hopefully see you in our fellowship. Thank you for joining us today. And here is our today's meeting agenda. So we are focusing on the complex respiratory failure, trying to make this complex problem easier to understand and easier to manage and to improve our patients' care. We'll start by a very nice and advanced presentation by Dr. Cam Boston from University of George Washington, USA. Is going to talk about point-of-care ultrasound and lung ultrasound in various types of respiratory disorders, focusing mainly on ARDS and respiratory failure. And then Professor Hibatullah Asal is going to talk about the ABC management, the bundles for respiratory failure. So here is our agenda. We have Dr. Khalid Al-Kathiri, who's going to moderate the session with us today, and Dr. Amr Abdulhamid is going to give a brief case-based discussion. With that, I'm going to let Professor Kim Boston from USA to give you the first lecture about lung and ultrasound and respiratory failure.
I'm going to try to organize this talk with four main objectives. We're going to briefly review lung ultrasound. We'll talk about some of the lung ultrasound applications, and then I'll dive into some of the critical care specific lung ultrasound applications. We'll end with a little bit of what the future holds for lung ultrasound as we get to the end of the talk. So quickly, a brief review of lung ultrasound. I like to start with this version of Harrison's, which was little over 20 years ago, and it said that ultrasound of the lungs was not a useful endeavor because it scatters the sound and it doesn't provide any meaningful information. And then one of the grandfathers of this science, to quote him, "In the quiet of an obscure hospital, the radiology department was not defended, and he stole an ultrasound machine and surreptitiously scanned patients in the intensive care unit and found patterns of sonographic images that aligned so tightly with the clinical treatments that he was doing that he created this art." And you can look at this, and if you look at this image of the lungs, you can see the ribs, the pleural line, and the A line all highlighted by arrows, and he described this as looking like a bat, the bat sign. Why this matters to me and why I got so excited about it is because ultrasound is a portable, inexpensive, battery-powered diagnostic tool, which means that you can use it anywhere in the world. The places where you can't get a chest x-ray or a CT scan, you can get an ultrasound, and lung pathology is incredibly prevalent in those regions. I quickly want to go through the physics of lung ultrasound because I think it's so fascinating and because I'm a little bit of a nerd, and I feel like this helps us understand what we're seeing. So typically what happens is that sound waves leave the transducer, hit the reflector of sound, come back up, and the transducer hears those and says, oh, there must be a bright white line at this depth. The pleura, however, is such a good reflector of sound that some of those sound waves bounce off of this inside of the skin, go down, hit the pleura again, and come back up, and the transducer says, oh, those sound waves have traveled twice as far. There must be a second pleura exactly twice as deep. This continues, creating a third and fourth reverberation artifact. In contrast, if you think about the patients that have fluid in their alveolar or interstitial space, the sound waves get trapped inside that little space and they create vertical artifacts made up of tiny little horizontal lines very close together, but they look like hyperechoic vertical lines going all the way to the bottom of the screen, and those are referred to as B lines. Solid structures look like liver, as you can see here with this densely consolidated lung just overlying the diaphragm. And if there is a pleural effusion, you can see fluid really easily with ultrasound. You can see the posterior acoustic enhancement and the atelectatic lung dancing inside this pleural effusion. When it comes to ultrasound, one of the complaints that many people have is that it's very operator dependent. And while that is true for many forms of ultrasound, particularly lung ultrasound is an achievable skill. And we refer to the counting of B lines as the kindergarten of echocardiography. This was a study comparing medical students with an hour of training to echosonographers who had been doing this for decades. And you can see that there is a very tight correlation in the counting of B lines acquired. And we can think about this as more than just A lines and B lines. We've moved past that. We can think about the lung ultrasound alphabet. So we have A lines, those horizontal hyperechoic artifacts that are present in normal lungs, COPD, asthma, PE, anything where there is normal alveoli and interstitium. We have B lines, where we have the hyperechoic vertical lines seen here moving back and forth, present in pulmonary edema, pneumonia, diffuse alveolar hemorrhage, anything where there is filling of the alveolar interstitial space or scarring of the interstitial space. Consolidations are present in pneumonia or dense atelectasis once you've totally de-aerated the lung, making it look like a solid organ. D stands for diaphragmatic ultrasound, and this is a growing field where we can understand the main muscle of respiration, and we can say whether or not that's a part of the cause of somebody's respiratory failure. E is for pleural effusions, and you can see that free fluid here. F is for feeding tubes, with this idea that we get a chance to see whether or not the feeding tube is traveling down the trachea or through the esophagus. We can also see the vocal cords here if you're thinking about evaluating that, but that's a more advanced skill set. G is for gastric emptying. In the era of GLP-1 inhibitors, it's really important to understand whether our patients still have a full stomach prior to intubation, or if that full stomach might be impairing their respiratory excursion. And then, just like my youngest daughter, we'll skip a few letters of the alphabet. We'll jump down to S, where we'll get to lung sliding, which allows us to rule out pneumothorax. T for a thickened pleura, which is present more in inflammatory and infectious states and allows us to differentiate them from the alveolar filling of cardiogenic volume overload. And Z for the Z lines, throwing back to the French originator of the lung ultrasound alphabet, which are present in healthy lungs, not necessarily a sign of pathology, but do rule out pneumothorax. Great. Now let's go into some of the lung ultrasound applications that are present for any specialty, not critical care specific. When it comes to lung ultrasound for hypoxemia, the original trial that Liechtenstein published was the Blue protocol. And what this does is he basically said, hey, I'm going to use no clinical information other than the lung ultrasound for a bunch of hypoxemic patients and tell you what their cause of hypoxemia is. I do want to put a little caveat here. Please don't do that. Please always use the clinical information that you have available to you, physical exam and history, labs, when you're trying to figure out the cause of respiratory failure in your patient. But I'll highlight the way that this was used. The first question he asked is, hey, is lung sliding present? And you can look here at this clip where I highlight the glistening, shimmering of lung ultrasound, and you can say, yes, lung ultrasound is present. We go down this channel. As a reminder, this is what non-present lung sliding would look like in a patient who had a pneumothorax. So since we know lung ultrasound is present, the next thing we have to ask is there an A profile diffusely or a B profile diffusely? And if you look at the same clip that we were evaluating before, you can see that there are B lines in comparison to the A lines highlighted, the blue arrow pointing to the pleura, the black arrows pointing to the A lines, both here and the B lines in this other clip. So based on the clip that I just showed you, with a present lung sliding and a diffuse B line profile, we would say that this patient most likely has pulmonary edema. The thing that I do want to throw out there is if you look at that algorithm, you can see that there's a lot of different ways to get to pneumonia. And it is useful to think about pneumonia because it's such a common cause of respiratory failure. We have a lot of different findings in lung ultrasound that are present in pneumonia. Air bronchograms, which are the most specific finding, a focal area of B lines, a para-consolidation effusion, subpleural consolidations or thickened pleura, and consolidations, frankly, being a sign of pneumonia. So if we think about that blue algorithm, we can see that there are multiple different pathways that end with pneumonia as the final diagnosis, whether that's an A profile with a focal area of B lines at the base, or if it's just a mixture of A lines, B lines, and consolidations, or if it's a absent lung sliding with B lines just about everywhere. So we want to think, is this a useful test? And when we look at the results from Lichtenstein's original paper, they may seem unbelievable. Look how high that accuracy is between those sensitivity and specificity figures. I'll offer that this is a select cohort that didn't include patients with pulmonary fibrosis, post-transplant, anything like that. That said, when we ask ourselves specifically about some of these diagnostic buckets, such as cardiogenic pulmonary edema, meta-analyses of thousands of patients continue to show extraordinarily high sensitivity or specificity, especially when compared to the diagnostic accuracy of chest radiograph or physical exam. Similarly, pneumonia, which had a sensitivity and specificity in Lichtenstein's study of 89 and 94%, has followed up in meta-analyses to have similar diagnostic performance, much better than what you'll get out of a chest radiograph or auscultation. Knowing that this is a useful diagnostic modality, let's think about the ways that it's already been used. And this is a study where we said, hey, if we have lung ultrasound and a pulse oximeter, do we really need the chest radiograph and ABG that we use to diagnose ARDS? There's a more general set of how to do this for the cardiologist in order to help them understand it. And we can get beyond just ARDS and volume overload to start looking at how to apply this widely, to the point that we can think about, is this a portable CT scanner instead of thinking about this as a portable chest X-ray? We can apply this in our patients with inflammatory lung disease and think about a rapid way in the clinic to detect the efficacy of immunosuppressive therapies. And this started to grow, and we could see year after year the number of publications looking at applications for lung ultrasound was growing until 2019. And then came the COVID pandemic. POCUS in general, not lung ultrasound specifically, but all over, thrives in a resource-limited setting, whether that limited resource is time, radiology equipment, space, or providers. And from the very beginning, we were getting descriptions of how lung ultrasound was presenting in patients with coronavirus and coronavirus-induced ARDS. We talked about how you could integrate this, and Dr. Risa Lewis and others created an article just describing that POCUS was having its moment in 2020. This is becoming standard of care in ICUs, and the pattern of lung ultrasound was being used to help us differentiate some of the questions that we had before. Is this ARDS? Is this volume overload? Is this both? And so this was an explosion of research, and I put that in quotations because while some of these are really useful clinical case reports, and some of these are very informed lung ultrasound anecdotes, the number of research articles doubled in a single year. And we really want to think about this as something we should be excited by, but also something that we should study with the same level of rigor that we would any other diagnostic modality. Because if we think about the patterns of lung ultrasound that were described in COVID ARDS, they're the same that are described in just about any form of ARDS, whether it's viral or bacterial. Outside of ARDS, lung ultrasound is used in patients with end-stage renal disease because we know that volume overload is such a critical part of their care. And we were able to do a study showing that the number of zones you scan will affect your accuracy, and that the number of B lines per zone can predict whether that patient is going to end up in the hospital or dead at the end of 30 days. We even started thinking about, can we use lung ultrasound to just forecast whether or not a patient is going to do well if they have end-stage renal disease and signs of volume overload? This collection of research got to the point where the American College of Physicians did a review of all the evidence and put appropriate use of POCUS for patients with acute respiratory failure in their recommended guidelines. And you can see that they were able to say POCUS augments our clinical ability, adds to physical exam and history. So that's more generally how we use lung ultrasound, but I want to talk about my favorite area, which is the ICU. So how do we use this in patients who are critically ill? And one of the things we can do is we can just say, hey, our patients are sick and complex, and oftentimes a chest X-ray does not give us sufficient information. And so a direct comparison of lung ultrasound to chest X-ray with CT scan as our gold standard shows us not just that ultrasound is more accurate than chest X-ray with CT as gold standard, but also where the places that lung ultrasound is going to fall down will be. And specifically, I'm talking about if you have areas of peripheral bullous lung, that's going to block your ability to see anything that's deeper and more anterior. Or if you have a mass that is surrounded by normal lung tissue, ultrasound won't see it and CT scan will. Or if you have a pneumonia that's hidden behind a gastric bubble, as is the case in this last slice of a CT, then you'll have a false negative on your lung ultrasound. This sort of refinement of the specific diagnostic accuracy of our patients is incredibly helpful in knowing how to use lung ultrasound in the ICU. Beyond that, one of the hardest questions that I sometimes am faced with is this opacity on a chest radiograph infectious or simply a matter of a patient being supine for too long and having atelectasis? And this study said, hey, can we use a couple of different findings to differentiate this? And you can see here an example of a patient with dynamic air bronchograms, which they found to be highly specific for pneumonia in comparison to atelectasis, with a specificity of 99% in their analysis. They also added color Doppler of these to see whether you could have signs of hyperemia in your infected patient versus normal blood flow in your atelectatic patient. The other thing that comes up frequently in the ICU is, does this patient have a new ventilator-associated pneumonia? And while we can do this with their existing standards, using chest radiograph showing new opacity, increase or change in character of sputum and other lab values, using lung ultrasound can help us make this more accurate. And this was a nice protocol where they said, hey, we want to suspect ventilator-associated pneumonia if they have one of these findings. Then we're going to do ultrasound, and we're going to add points to our ultrasound to make a score, and we're going to take the combination of clinical indicators and ultrasonographic indicators, and they demonstrated that this is highly accurate for the clinical diagnosis of ventilator-associated pneumonia. Another question that arises is this a simple volume overload driven effusion, or is this an effusion that's becoming an infected space that we need to think about drainage of? And so this is where we looked at, can the ultrasound findings differentiate transudated from exudated pleural effusions? And what we found is that anechoic fluid does not help change our post-test probability of this being transudative or exudative. But a highly echoic fluid, as seen here, or a loculated space, as seen here, are super helpful for helping us understand whether or not this space is infected. Beyond just diagnosing whether or not we think that a fluid space around the lung is infected or not, we need to be using ultrasound to guide our thoracenteses. And whether that's just marking a space and making sure that there's no blood vessels, as seen here, or in this new protocol proposed in the POCUS journal, are we thinking about a standardized approach for visualizing the blood vessels above and below the space in which we're thinking about putting our needle in order to understand if our patient has an unusual vascular anatomy that would put them at higher risk, as seen with this artery that's somehow right in the middle of the rib space. We can also think about using POCUS to meet our diagnostic criteria for ARDS. This was originally described in what's known as the Kigali modification of the Berlin criteria for ARDS. But in the last year, both the American and European groups have created new definitions for the acute respiratory distress syndrome. And you can see specifically that they call out ARDS in a resource-limited setting where you can use POCUS instead of chest radiograph or chest CT to meet your necessary imaging diagnostic criteria of bilateral abnormalities. Beyond just making the diagnosis of ARDS, though, we can use scoring systems that have been proposed for understanding whether or not people are getting better. And so this is where you take somebody who has ARDS and you look at each zone and you say, does that zone have an A-line pattern, a pattern with discrete B-lines, a pattern with confluent B-lines, or consolidations, and you give them points increasing as they move from one to the other. Based on these number of points and sum, you can start to understand a little bit about not just the severity of the imaging findings of their ARDS, but also are things are getting better or worse. So for example, one of the first ways that they used this was to say, hey, can we use this to guide recruitment with PEEP? And they did this by taking a patient down to 0 PEEP, or ZEEP as it is colloquially known, and then adding PEEP and seeing what happened to the lung ultrasound findings to identify recruitable zones of lung. The protocol here is very clever, and they were able to show that this indicated which parts of the lung were going to be recruitable and which parts weren't. When they did that, they had very tight correlation with their exhaled tidal volumes. The other primary therapy for ARDS that we know works is prone positioning for moderately severe ARDS. But sometimes we will wonder in our patients who might be at higher risk for proning, whether that's for hemodynamic instability or for skin vulnerability, we'll wonder whether they're likely to benefit from an oxygenation standpoint. And so this study was able to show that if you look at those lung zones and score them in the same way that we did before, that you can predict a pattern, more posterior, higher scored zones being the patients that are more likely to have a response to prone positioning. And that response is seen both in imaging and potentially in oxygenation. I do want to put the caveat here that I teach all of my trainees, which is that the benefits of prone positioning in terms of mortality in ARDS are not necessarily dependent on the improvement in oxygenation, but this can be helpful when we're trying to come up with a plan for the day. As I said before, one of the main questions we have in our critically ill patients is, are the imaging abnormalities I'm seeing from volume overload, or are they from progressive ARDS, cardiogenic or non-cardiogenic pulmonary edema? Capetti et al. Tried to answer this by looking at groups of patients that had known ARDS and groups of patients that had known acute pulmonary edema. And when they did that, what they found was that B lines were present for all of these patients. But if you looked closely at the pleura, you could see a pattern where the cardiogenic pulmonary edema patients had smooth B lines, and the ARDS patients tended to have more commonly pleural changes. Similarly, you could look at reduced or absent lung sliding and the presence of consolidations or effusions as being useful for differentiating the two groups. This has been validated in further follow-up studies, helping us understand the utility of this technology. If you have identified that your patient is volume overloaded, then lung ultrasounds has a new utility, which is, hey, how much congestion remains? Because you can quantify it in a way with B-lines that you really can't with chest x-ray. And so when you look at this, they looked at patients who had more than 15 B-lines and they said, wow, this really predicts event-free survival from heart failure patients when they're discharged. Those are the ways in which lung ultrasound is currently being used. I want to talk now a little bit about where I see the future of lung ultrasound going. And one of the first places is expanding the indications. We're learning more and more about how lung ultrasound presents in different pathologic etiologies. And so, for example, PE, which is typically described as just having clear lungs, can actually have small microconsolidations, and you can look at the blood flow inside of them to say, hey, is this because of an infectious inflammatory etiology, or is this because a clot is preventing blood to get into that portion of the lung? And then there's this idea that you could use ultrasound contrast to actually see the blood flow inside of the lung and understand where in the lung is not getting blood flow. Beyond this, I like the idea that lung ultrasound is easy to do, and so it should not be limited to just the intensive care unit. Obstetrics and gynecology residents are learning how to do this to help look for peripartum and postpartum cardiomyopathy. They're looking for amniotic fluid embolism. The family medicine group has said in their ACGME guidelines that this should be a part of every primary care doc's residency training. And when it comes to intraoperative lung ultrasound, there are a number of ways that you can apply this while the patient is on the table in the OR. And then afterwards, you can look at their lung ultrasound findings to see whether you can predict who's going to have this more complex postoperative course. Not just limiting this to the area of the intensive care unit, we can think about not just limiting it to physician scanners. We can see that APPs are starting to do this, and respiratory therapists globally have started to be involved in research on the applications of lung ultrasound performed by RTs. Nurses have been using lung ultrasound in order to make diagnoses of pneumonia in dyspneic patients and to help with triage in the ER. And then if I'm trying to think about where the best financial return on investment is with the prevalence of heart failure, it's got to be understanding if I'm making progress in getting my patient to their ideal volume status as quickly as possible. And so this is demonstrated in studies where we're trying to teach internal medicine teams to use lung ultrasound to drive their diuretic goal, to decide when a patient's ready for discharge, or to decide whether or not a patient's going to be readmitted. As I said before, lung ultrasound is a study of artifacts, and so we're learning how to refine our technique in order to make sure that those artifacts are as visible as possible, and that might mean changing the depth, the gain, which presets happen in the back, and where we set our zone of focus. We also have the idea that the traditional zones of lung ultrasound are not necessarily the only zones of interest, and maybe we should be just sweeping the chest, understanding from top to bottom and covering a lot more surface area in order to get a better big picture. When it comes to the even more advanced cases, if you already have a transesophageal transducer inside of a patient in order to look at their heart, you can also look at their lungs. And this is described in a couple of case reports in CHEST, where they were able to show that by doing so, they could identify a PE or a patient with refractory atelectasis while in the TEE suite. And then we have been stuck with this handheld probe for a long time, and I love it, but there are more and more scientists working on the idea that we're going to just put ultrasound wherever we need it to be and can leave it there in order to understand over time what's happening below that ultrasound patch. Outside of the hospital, we were able to show that you can do lung ultrasound on home visits and answer important clinical questions in a patient that can't be moved to a chest radiograph or who can't have blood drawn easily. And you can use this to adjust therapies in the hospital at home patient. And if we're saying we don't need to be in the hospital and we're saying we don't need doctors to do it, then the next step is, can we have our patients doing lung ultrasound on themselves? And the answer is probably yes, as an increasing number of case series have demonstrated. So to wrap this up, just think about what I want you to take away from today's talk. We briefly reviewed lung ultrasound, and I said before, and I'll say it again, this is one of the easier applications for POCUS. We have an alphabet that helps to guide us, and it works for all sorts of different lung pathologies. When it comes to how we're using it, we're starting to understand that for just about everything, it's better than a chest radiograph. And you can see a lot of different pathologies with it, not just our traditional volume overload versus COPD. And it's becoming a part of the general guidelines for specialty and national societies. In critical care specifically, we can use it to make diagnoses, and we can use it to predict response to the therapies that we use for our patients. And in the future, we're going to have this being applied outside of the ICU, outside of the hospital, being used by non-physician providers and by patients themselves, breaking the boundaries on how this technology can be applied. Thank you so much. As we conclude, lung ultrasound is growing in popularity. The evidence base is exploding. In critical care, our ability to detect ventilator-associated pneumonia, pneumothorax, and modify our ARDS management is incredibly exciting, and the future of lung ultrasound is going to incorporate a lot of new techniques. Here's some citations. That was a bit of a whirlwind of evidence review. Thank you so much. I'm excited to talk to you about questions.
Very amazing presentation. I think every single physician dealing with a critically ill patient should understand the basic of using point-of-care ultrasound. Even our medical student nowadays, it's part of their curriculum to learn how to do the simple point-of-care ultrasound evaluation with the soft tissue, the lung ultrasound, IVC diameter, and so on. So it's very important. If you are a physician who is dealing with critical ill patient, you need to train yourself. You need to get trained. And actually, we have a POCUS fellowship for 1 year. If you are interested, you can join it. And also during this respiratory critical care fellowship, we're going to teach you and help you how to apply this point-of-care ultrasound evaluation in your practice. So we'll do a shift from diagnostics to therapeutics. Professor Heba Asar is going to teach us what we need to do to treat our patients with respiratory failure. There is a respiratory failure bundle that we need to use, and she's going to teach us how we can do the A, B, C, D, E, and whatever letters she's going to teach us to give us a brief introduction how to better treat our patients with respiratory failure.
Hello, everyone. My name is Hibatullah Asal, Professor of Chest Diseases, Faculty of Medicine, Cairo University. Today, I'm going to talk about the critical care bundles for respiratory failure. First of all, a care bundle is a group of 3 to 5 evidence-based interventions which, when delivered together, lead to a better outcome than performing interventions individually. The ABCDEF bundle includes A, assess, prevent, and manage pain; B, both spontaneous awakening trials and spontaneous breathing trials; C, choice of analgesia and sedation; D, delirium, assess, prevent, and manage. E, early mobility and exercise. F, family engagement and empowerment. The ABCDEF bundle is a transformative framework that translates critical care evidence-based guidelines to address key dimensions of ICU care, such as pain, agitation, sedation, delirium, and mobility and family engagement. As we all know, these entities are very, very important in the patient's outcome. However, they are underlooked and underestimated from the busy physicians and busy nurses. So this why clear bundle that has to be implemented with predefined protocols should be implemented and assessed regularly in order to make sure that avoidance of pain, agitation, and encouragement of early mobility will be done on an objective, regular basis. So studies had shown that adherence to the bundle components led to reduction in duration of mechanical ventilation and decrease in ICU stay, and that consistent of use of the bundle reduced the incidence of delirium, and also it had led to better functional outcomes for the patient, such as ability to sit, stand, and walk, with higher quality of life scores after discharge. So in the next coming slides, we are going to summarize what has been published in the clinical practice guidelines for management of pain, agitation, and delirium in adult patients that was published in the Intensive Critical Care Medicine Journal in 2013 and was further updated in 2018. We are going to share the information in a simplified, easy to implement way. The first part of the bundle is the A, which is assess, prevent, and manage pain. And when we are talking about pain simply is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Different surveillance studies had found that patients with history of psychological disorders, younger age, female gender, history of comorbidities, history of surgery, and non-white ethnicity, these patients were found to have increased risk of sensation of severe pain. ICU patients commonly experience pain with incidence of about 50%. Assessing and treating pain is very important to prevent and manage delirium, as both are very closely related, and we will talk about delirium later on. It has a deleterious effect on the patient outcome, so we have to prevent what causes delirium. Severe pain negatively affects patient status. For example, if the patient is in pain, he may be cardiacally unstable, tachycardic, bradycardic, hypotensive, hypertensive, so on. If the patient in mechanical ventilation and feels that he has pain, significant pain, maybe he will fight the ventilator. This will prolong his weaning from the ventilator. Also, this was found patients that were untreated from their continuous sensation of pain were found to be more immunocompromised and had more instances of acquiring ICU infections. So implementation of assessment-driven and standardized pain management protocols was found to improve ICU outcomes and clinical practice. So how to objectively assess pain? We have to first detect the pain in order to manage. So if the patient is able to communicate, the best method is the NRS, which was considered the gold standard for assessment of the pain, which is the 1 to 10 numerical rating scale. The patient is asked to give himself a grade, whether it's from 1 to 3 out of 10, so it's mild, 4 to 6 is moderate, and 7 to 10 is severe. And if the patient has NRS above 4, this is considered significant and needs to be treated. What if the patient cannot communicate and is unconscious? I start to observe the patient, and this is different pain assessment protocols, either CPOT, critical pain observation tool, or behavioral pain scale. I start to observe the facial expressions, whether it's relaxed or tensed. I start to observe the movement and see whether he is compliant with the ventilator or coughing or fighting with the ventilator. I start to hear the voices that is coming out of the patient and see whether this muscle is relaxed or tense. And each item is given a number, and it's added numerically to give a score. So if the BPS is above 5 or CPOT above 3 is considered significant and needs to be treated. So according to the guidelines, I have to treat or manage this pain if these scores, as we have said, are significant, or if I am going to perform a painful invasive procedure such as arterial catheterization or removal of intercostal tube, or any painful procedure that is supposed to cause pain, I have to give prophylactic analgesia before, according to the guidelines. So what are the pharmacological agents to treat pain? The first line is the parenteral opioids. They are very effective, such as fentanyl, remifentanil, morphine, and hydromorphine. However, they cause sedation, delirium, and cause respiratory depression and maybe ileus, and may lengthen the ICU length of hospital stay. So for this reason, it was recommended by the guidelines to use a multimodal strat analgesia. This means to use opioid and non-opioid analgesia to augment the effect of the analgesic effect of the opioid and to reduce the opioid consumption. These are the opioids that we use in the ICU with their dosing and their infusion rates. You can refer to the slides later. And the non-opioid analgesia that should be given with the opioid to decrease the opioid consumptions according to the recommendations of the guideline. Acetaminophen is the first line non-opioid analgesia that is recommended to be given, and it's very patient and physician friendly. Nifopam is a very good analgesic that exerts its effect by inhibiting dopamine and noradrenaline and serotonin. However, it's not present in all countries. For me in Egypt, it's not present, but some countries there is Nifopam, and the literature is very supporting with its use in the ICU together with the opioid in order to decrease opioid consumption. Ketamine, we usually use it with fentanyl in order to reduce the required doses of the fentanyl. It's very effective. It's N-methyl D-aspartate receptor blocking agent. Neuropathic medications such as Gapten and carbamazepine and pregabalin were found to have a significant decrease in opioid consumption, as were found to be very efficient. However, they should be introduced in an enteral way, so the patient should receive it enterally if this is feasible. Intravenous lidocaine and non-steroidals are not recommended by the guidelines. Non-pharmacological interventions such as massage, music, relaxation techniques are recommended in the guidelines, have also been shown to reduce opioid use. Now we are talking about the B part of the bundle, both spontaneous awakening trials and spontaneous breathing trials. So daily spontaneous awakening trials are the stopping of narcotics as long as pain is controlled, and sedatives every day. And if needed, restarting either narcotics or sedatives at half the previous dose and titrating as needed. Daily interruption of sedation shortens the duration of mechanical ventilation and length of ICU stay, as was proven by studies. The ICU PAD guidelines emphasize the importance of minimizing sedative use and maintaining a light level of sedation in patients using either a daily sedative interruption strategy or by continuously titrating sedatives to maintain a light level of sedation. We should target a level of sedation in an objective way, and we are going to talk about how are we going to assess the level of sedation. We are targeting a light level of sedation by the RAS, for example, the RAS assessment tool. This study was done on patients that were subjected either to light sedation versus deep sedation, and it was found that patients that were subjected to light sedation has improved survival. Deeper sedation was associated with longer duration of ventilatory support, more tracheostomy, and increased hospital mortality. And this is the RAS score that I'm talking about that should be implemented in all patients and should be revised day after day for each single patient in order to revise the sedative use and the sedative doses. And we are targeting a level of -2 to +1. We don't want the patient to be very agitated, pulling or removing tube or being harmful to himself or others. And we don't want this deeply comatose patient that is not responsive to voice. We want this category of patient that are either alert and calm or not fully alert but has sustained awakening to voice or briefly awaken to voice or apprehensive but movements. Maybe we can accept some anxiety, but movement should not be aggressive or vigorous. So this is the level of sedation that we target for our patients. What about the component C of the bundle, which is choice of analgesia and sedation? The PAD guidelines emphasize the need for goal-directed delivery of psychoactive medications to avoid oversedation, promote earlier extubation, help the medical team agree on a target sedation level by using sedation scales. So what are the common sedatives that are used in the ICU? Either we use benzodiazepine like midazolam, lorazepam, diazepam, or non-benzodiazepine sedatives such as propofol and dexmedetomidine. And when we talk about the sedatives, we usually prefer the non-benzodiazepine over the benzodiazepine because it was found that this benzodiazepine, such as this study that compared dexmedetomidine, which is non-benzodiazepine sedatives, versus lorazepam, which is a benzodiazepine, in patients, and it was found that patients that were subjected to the lorazepam has much lower survival. And for this black bars, that represented patient that received lorazepam versus the gray bars, patient receiving dexmedetomidine, the patient with dexmedetomidine had much less risk of delirium. This is for all patients for the study. And when further analysis was done on septic patient, this effect was more pronounced. The message that we want to deliver is better to use non-benzodiazepine to decrease the risk of delirium and to improve survival, especially in patients with sepsis. So different studies showed that decreased exposure to sedatives, particularly benzodiazepine, is associated with improved patient outcomes. It's essential to carefully choose sedatives and analgesic medication, as well as consider doses, titration, and discontinuation. This statement was taken from the guidelines, the pain, agitation, delirium guidelines that was published in 2018, and it was suggested using either propofol or dexmedetomidine over benzodiazepine for sedation in critically ill, mechanically ventilated patients. The D part of the bundle, which is delirium, and is very important to assess, prevent, and manage delirium. As we all know, as a clinician in the ICU, that most of the patients in the ICU develop delirium, especially if they are old age, and most of the population in the ICU are old age, so most of them develop delirium. And usually there is a study surveillance study that said that 80% of patients develop delirium during their ICU stay, usually between the second and third day, which is a very big number. And when we know that delirium is associated with a very poor prognosis, so we have to take care. So how to objectively assess whether this patient will be labeled as delirious or not? By applying this ICU flow sheet. So if the patient has 1 + 2 plus either 3 or 4, the patient is considered delirious. In other words, if the patient has acute change of fluctuating course of mental status, inattention, like when I say to the patient, just squeeze my hands and start to say letters and say to him, squeeze my hand when I say letter A, and he does not delineate between S, A, V, and he does not obey my order. So this patient has inattention, and this entity is considered positive. If the patient has altered level of consciousness, or if there is disorganized thinking, he cannot answer the very simple question like, is there a fish in the sea? Does 1 pound weigh more than 2? If the patient cannot answer these simple questions, he's considered to have disorganized thinking. So having 1 + 2 plus either 3 or 4, so we say that the patient already developed delirium. So what are the risk factors for delirium in order to reverse it? As we have said, studies have shown that benzodiazepine use was closely related to development of delirium. So try to avoid benzodiazepine. Surveillance studies had shown that patients that were subjected to multiple blood transfusions were more to have delirium than others. Non-modifiable risk factor, of course, old age patient with dementia, patient that had previous coma or pre-ICU emergency surgery or trauma, or increased Apache score make them more subjected to develop delirium. Delirium can be categorized into subtypes, either hyperactive, which is associated with agitation, and it's had better prognosis than the hypoactive, which is associated with decreased responsiveness and apathy, and is usually more deleterious. As we have said, that evidence showed that delirium is a strong predictor of increased length of mechanical ventilation, longer ICU stay, increased cost and long-term cognitive impairment, and increased mortality. So how to treat this serious entity that usually we found in most of our patients? According to the pain, agitation, delirium guidelines, it is not suggested to routinely use the antipsychotic as a prophylactic or treatment of delirium. However, according to the panel experience, if the patient experiences significant distress secondary to delirium as anxiety, fearfulness, hallucinations, or delusions, or who are agitated and may be physically harmful to themselves or others, they may benefit from short-term use of haloperidol or atypical antipsychotics such as risperidone and intravenous haloperidol, as we've said. Also, patients that are mechanically ventilated and agitated, and this precludes weaning, we can use dexmedetomidine to treat this hyperactive delirium. The most important is the non-pharmacological intervention, which is very effective, as we have said, by reducing modifiable risk factor Try to improve cognition, as this patient is usually confused after a couple of days. He doesn't know whether it's morning time, it's night time, where he is. So try to do what is called cognitive stimulation and use of clocks and talk with your patients. Also try to provide him a good quality sleep by minimizing light and noise at night, improve wakefulness by reducing sedation, encourage mobility as early as possible, and if the patient had reduced hearing or visual impairment, let him use his devices such as hearing aids or eyeglasses to make the environment more clear. The more clear the environment, the less he will develop delirium. Also, family engagement is very, very important to decrease the incidence of delirium, as we will say. Early mobility is very important. As we know, usually the patients critically ill have what is called ICU acquired muscle weakness. They develop it very quickly. And this muscle weakness is closely related to poor prognosis and deleterious outcomes, especially in patients with respiratory failure or patients that are mechanically ventilated. We want his diaphragm intact, we want his muscles intact for good cough reflex, for good breathing, to be able to be weaned off. So studies had shown that during ICU stay, critically ill patient can lose up to 25% of their peripheral muscle mass within 4 days when mechanically ventilated, and 18% in body weight by the time of discharge. The reported incidence of ICU acquired weakness ranges from 25 to 100% and is associated with impairments in patients' long-term survival, physical functioning, and quality of life. The pooled estimates from 6 randomized controlled trials showed that rehabilitation improved muscle strength at ICU discharge and reduced duration of mechanical ventilation. And also, according to a recent meta-analysis, serious safety events or harms do not occur commonly during physical rehabilitation. So we have to encourage the ICU staff to start implementing pulmonary rehabilitation for the critically ill patients, so long there is no absolute contraindication, and don't be afraid from doing harm to your patients so long you are taking all the safety measures. And this study was published in The Lancet, and they found that patients that were subjected to early exercise and mobilization in the first 3 days, this study was done in mechanically ventilated patients for less than 72 hours, and they were assigned to early exercise and mobilization. And this study has shown that these patients had better functional outcomes at hospital discharge and shorter duration of delirium and more ventilator-free days compared with standard care. So if the patient is unmechanically ventilated, so long that there is no contraindication, so long that the patient is vitally stable, move your patients. Try to move your patient as early as possible. And the earlier, the better, because in the first 3 days, the patient still has a good muscle. However, the later you start the rehabilitation, the patient usually had acquired the weakness, and it will be difficult to reverse it. So the earlier, the better you start moving your patient. Even if the patient is on mechanical ventilation, yes, he can stand and he can walk. So rehabilitation could be started as early as possible, so long the patient is vitally stable cardiovascular, the patient is respiratory stable, he's not severely hypoxic, and he can open his eyes and obey commands. However, if the patient has cardiovascular instability or respiratory instability or changes in consciousness, you should wait for him. Lastly, the family engagement is very, very important and is usually underestimated and underlooked by the staff, because usually the ICU, the critical patients, usually the family is allowed to visit their patient maybe for 1 hour a day. However, studies have shown that patients that had their family by their bedside for a longer period of time are much, much less to develop delirium and had much better prognosis. Family offers emotional support, offers cognitive stimulation. They help the ICU team in mobilizing and moving their loved ones. And also they participate and talk with the doctor, with the medical team, and to know the right prognosis of their patient and to be engaged in different decisions. And they know whether the patient has a bad prognosis, a good prognosis, and they help also the medical team in delivering the information to their loved ones. So family engagement is very important, and this study emphasized this, as we have found, and this study had found that patients that had their relatives with extended visitation model, extended the visiting hours to 12-hour daily led to 50% reduction in delirium incidence, which is a very, very significant result. Just changing one variable, which is the visiting hour, led to 50% reduction in delirium. Also, this study was published in Lancet. In 2088 COVID-19 patient that had the opportunity for their family to visit them either in person or virtual, these patients had lower risk of delirium. So it's very important to start to talk to our medical teams and our staff in order to change the culture that families should not enter and so on. No, families should enter and should participate in caring for their loved ones. And we have to implement some sort of protocols in order to allow families to be engaged without burning out our staff or causing overburden. So my take-home message is that ABCDEF bundle A2F is an evidence-based set of 6 steps that aim toward an awake and walking ICU culture. The A2F bundle is a way to bring a humanistic approach to ICU care with the backing of rigorous scientific evidence. Higher compliance. Studies had shown that higher compliance with the A2F bundle, 6 steps, has been shown to reduce delirium, ICU length of stay, mortality, and ICU readmission in a dose-dependent manner. And thank you.
Thank you so much, Professor Heba, for this very nice presentation. There is a room for a couple questions, so we have only 5 minutes left. So please, if you have any more questions, feel free to put your question in the QA box. Just a quick question for you, Professor Heba. So this ABCDEF bundle, is it inflexible or flexible? Can we personalize it or individualize it according to the patient physiology, pathophysiology, the patient need, or it's just fixed ABCDE bundle?
Yes, of course. Now we are in the era of personalized medicine in different disciplines. So personalized medicine, it's very important that each patient, it should be treated according to his physiology and pathophysiology. As I have said, for example, if I want to mobilize my patient, I should be aware of his restrictions, of his whether he's vitally stable or not, whether he has any like injuries or traumas and so on. Analgesia, sedation, family engagement, all of these are very, very mobile and could be changed from institution to another according to different staff. We are optimistic and we want to implement everything together, but this make obstacles in doing that. We have to know that we have been years and years practicing ICU in a culture that is what I so-called is very closed and very private place. Families are not allowed to engage so much. Mobility, for example, I had a patient in ARDS and I had one of my team, a respiratory therapist team, and the patient was doing good like the second or third day. And then when I was having my clinical round, I found this patient intubated and walking. I was astonished, and some doctors start to accuse this RT that he's doing that he's malpracticing. However, he's doing right thing. He's mobilizing the patient early. He was a young patient, so his muscle reserve allowed us to do so. He was walking while he was intubated, like few steps around the bed, and this patient did not have specific contraindication in order to stand or to walk, and this patient has very, very, very good prognosis. I mean, like he was disconnected early, he was discharged early. So the thing I want to say that there are a lot of obstacles we will face in order to implement this bundle. First of all, awareness. Number one is awareness to the nurses, to the physician, to the staff, and to deliver this scientific evidence in order they will be comfortable to do something weird, like I have said. Maybe they are not acquainted to just walking the patient while the patient is connected to the ventilator, or the family, or one of the family is sitting beside the patient for an extended period of time. So we have to disperse the knowledge, and different patients with different pathophysiologies, with different contraindications, like I have said, for example, some analgesia are not preferred. For example, like patient with abdominal surgery, we don't prefer to give them fentanyl, for example. We are afraid from the opioids causing ileus. There are different pathophysiology with different indications and contraindication, and it's a matter of art. Medicine is a matter of art and personalized medicine at all at the end of the day.
Thank you so much, Professor Herba. Just very briefly, we have still three, four questions, and I need your answer to be in bullets instead of in text. So,
Yeah.
if you choose one bundle component, and this question came in from Dr. Khattab, which one bundle component would be strongly associated with improving our patient outcome and our, patient survival?
This is a very good, and I think it's a challenging question. But I think the sedation, if I'm going to use a one bundle component, it's using the light sedation versus deep sedation will improve the outcome of the patient. For the second question, how the bundle be applied in case of restrictions like limited mobility or severe delirium or limited family. As I've said, every patient is treated differently according to his limitation, but any form of movement is encouraged by the dedicated team instead of no movement at all. Can physiotherapy be carried out in patient with, you mean ARDS during proning? No, no, during proning, you are giving your patient deep sedation and muscle relaxant. So, and the patient is respiratory unstable because the criteria to prone the patient that the patient is severely hypoxemic. So if one of the contraindication to move the patient is severe hypoxemia and the patient require a high level of PEEP. So no, no, I don't do this in this phase. So proning is done as early as possible after 48 hours of admission of the patient. Yeah, the patient that I'm talking about, like this, we started to move him after I think the third day. He was doing good. He was his oxygenation. We did the proning. The patient improves very good, and we off the sedation. And the patient was young age. He has good muscle reserve, so we start to move him. This is what I'm saying about my patient that I'm talking about. Is it practical to mobilize a ventilated patient with endotracheal tube in situ? Yes, yes, we can move the patient, but as I've said, every patient should be treated individually. Not all patients can stand while on mechanical ventilation. No, we cannot do this for every patient. So every patient, according to his comorbidities, according to his age, according to his muscle reserve, how we can apply the proper exercise for him, but not every patient can move while intubated. I mean, it's more practical for chest and limb physiotherapy. Yes, 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 this is the basic. What I'm talking about is out of basic. It's just to go to the ICU and see the intubated patients walking around. This is very weird. I know. Yani, this was a case, and we just tried publishing because this is not the practical. This is not the routine. But however, as I've said, the patient has no comorbidities. He was 30 years old. He has very good muscle reserve. He was subjective to acute insult that caused ARDS, and he recovered after like 48 hours. So this why the patient was moved early. What contraindications about hemodynamics, vasoactive doses for rehabilitation? It's a matter of blood pressure. So if the blood pressure is high, if the patient is hypotensive or hypertensive, we don't do this. There is specific cutoff I've written in the slide. So if the blood pressure below 60 or above 150 systolic blood pressure, no, this patient is should we have to stabilize his vital signs before doing so. So if the hemodynamics are of increased doses and I'm increasing the vasoactive doses, for example, is increased doses and I'm continuously increasing the dose to maintain the blood pressure, no, of course we don't do this. How about mechanical ventilation parameters? You mean like mechanical ventilation parameters while I'm moving the patient? This is what I've understood from the question. So, as I've said, the patient should not have respiratory compromise. This means that the FiO2 requirements for the patient should be of acceptable range. High FiO2 and high PEEP requirements will preclude doing the rehabilitation. However, lower the FI2, for example, 40% and PEEP requirement less than 10, enable me to move my patient and do the rehabilitation. Any other questions?
Yeah, let us just end up with this question. It's another smart question. In patient with severe respiratory failure who remains hypoxic despite optimal FiO2, say FiO2 of 100% and the maximum beep, what would be the escalation strategies within this bundle, including all maneuvers, prone positioning, neuromuscular blockade, ECMO, and others?
If we are talking about the bundle in the severely hypoxemic patient, maybe you are restricted to if you are going to talk about implementing the mobility and reducing the agitation. So for reducing the agitation, for example, this patient will be subjected to a lung protective strategy, lower tidal volumes. So we have to sedate the patient. You're not going to talk about light sedation in this critically ill patient. We have to deeply sedate the patient. And also maybe we are going to talk now about family engagement. Family must be engaged with this patient in order to know the prognosis. For early mobility, no, I'm not going to move this patient in this stage. For the delirium, I might prefer not using too much benzodiazepine. I will prefer the non-benzodiazepine, because if this, after recovery of this patient, if we did, like we have seen in COVID, like patients were mechanically ventilated for a longer period of time, and those who recovered, they take a very long period in doing in rehabilitation and movement, because they were subjected to very high doses. Usually COVID patient required than other patient high level of sedation. So we'll try to minimize the level of sedation and choose the non-benzodiazepine versus the benzodiazepine. The same apply for analgesia. We'll try to apply the multimodal strategy for analgesia instead of giving high doses of opioid, and the patient like will need more and more doses afterwards if it is given for a long period of time. Regarding the spontaneous awakening trial and the spontaneous breathing trial, maybe if the patient, as you've said, it's on FiO2 100% and it's for high level of PEEP and in prone, no, I'm not going to do this in the current situation. This is briefly what's my opinion in this patient.
Last question. If the patient is still mechanically ventilated with endotracheal tube in place, would you recommend mobilizing the patient or just doing chest and limb physiotherapy instead?
According to the patient, as I've said, each patient should be treated individually. So if the patient is in a good shape, if the patient is vitally stable, if the patient is in low oxygen requirements, and there is no specific contraindications regarding like trauma or surgery or something like this, now, yes, I can even just sitting, yeah, so the patient can just sit and then lie flat. There is an entity called verticalization. Even the bed, some beds are designed just to be vertical, as if the patient is standing. However, the patient is wrapped inside this bed and then lies flat again. And verticalization is a scientific. It has been studied in different studies, and it shows in patients with ARDS that verticalization improved the patient's outcome. So any form of mobility according to each patient type will benefit the patient. Even if just I'm moving the patient just standing up while he's still in bed and then get lying flat. Usually, what we usually do, we just try to let the patient sit in the bed so long he's hemodynamically stable and no contraindications, no joint affection or so on. We just try to let the patient sit in the bed. And if the patient can stand, this is very good.
So very well said. And I will just add, according to whatever I have learned from you today, that endotracheal intubation doesn't preclude the physical therapy.
Yes, yes. And this is proven by the studies that I have just mentioned. The Lancet
Right.
study did this study on patients that were intubated, and it showed very good results.
Thank you so much. That's a great webinar. I think we are all learning a lot today. With that, I'm just going to give some last messages. All of the attendees today should receive their certificate of attendance by next week. All of you should also receive the link of the recorded webinar by tomorrow, and we'll send you a feedback form. Please help us to improve our webinar's performance. If you are interested to join the online Respiratory Critical Care Fellowships, I think you will have this link in the chat box. So please join us as soon as possible. You can take advantage on the promo code. We'll be in touch. We'll send you email orientation and notification about our upcoming educational activities. Thank you. Have a good day, good afternoon, good night.
Thank you.
Mhm.